मेरे को देखना है। Hey, hi guys, welcome back, and today we are going to discuss why the QBank 6.0 is the best thing for you to read when you're going to revise for exams. Yes, the exams is on 23rd of June. You guys were just discussing on the chat when is the exam. It is very much on 23rd of June. The notice came out on 20th of March that we're doing it on 23rd of June. So don't wait for any more, adjournments, don't wait for any postponements, and yes, it does not get advanced most of the times, and in the scenario of elections, if at all, it may get postponed, but not earlier. So I hope it doesn't get postponed. All of you should get into your post-graduation as early as possible. So when we're talking about Question Bank 6.0, it is our effort to give you a whole set of new questions and make sure that the old ones, which were having a lot of doubtful choices and poor recall, we've tried to get those questions into good shape so that when we read this QBank 6.0, then this is the first and the last stop for you to make your revisions after you've done your initial preparation with the theory part, right? So I'll just tell you that some of these questions are like the recall types, some of the questions are good long clinical situations, and some of the questions are the routine questions which are very factual. So let us see what kind of questions are there. Some of them I've got from Obs and Gynae here. I'm sure the other specialties have also shown you how the question bank has come up this time. So let's see. We'll see the first question which I've got for you. It is a clinical question which is about a 45-year-old female with complaints of lower abdominal pain, pressure in the pelvic region, and loss of appetite. Her ultrasound shows bilateral ovarian masses along with ascites. Additionally, there is omental caking on a CT scan which is noted. What is the most likely diagnosis? So yes, from the beginning, these are the kind of questions which come in the exams where they will lead you, to a situation where it should be very clear. The exam questions are extremely, clear because they are meant for assessing how much you have understood in the basic scenarios of MBBS situations. We are not trying to test if you are a postgraduate in Obs and Gynae. We are not trying to test if you are a specialist in Obs and Gynae. We are trying to test that if you know a woman who is having a bilateral ovarian mass and she's having loss of weight and she's having loss of appetite and there is omental caking, at least you should think of ovarian cancer first. All right. So this is something which you should not be missing at any cost. It's a clinical situation which may make you think of other problems also. But since we have a mention of loss of weight, right, we are thinking in terms of malignancies. Okay, so yes, it is most likely what kind of a condition in a woman. It is very important note what is written here. Yes, omental caking. Just a minute, I have to choose the. Yeah. The omental caking which is mentioned here, that omental caking is the one which should tell you that when a ovarian tumor has spread into the abdomen and is involving the omentum, then the omentum gets all bunched up because of the growth. So that is what is known as a omental cake. So that is what is a straightforward indication for you to think of a malignancy than a benign ovarian tumor. So around 45-year-old woman who is having a likely malignancy of the ovary and with the omental caking, what are you going to think most likely? Yes, it can be many types of ovarian malignancies, but the most common ovarian malignancy is the epithelial ovarian malignancies. Almost 70 to 80% of all ovarian tumors are the epithelial ovarian tumors. All right, so this is a malignant epithelial ovarian tumor. Now, in addition to this, we'll tell you much more information, not just that this is the answer. We'll tell you in the app and in the question bank that what makes you think that on the ultrasound it is a malignancy. What makes you think in clinical features? So we have this risk of malignancy index, all right. So there are many types of risk of malignancy indexes, and the original one I'm showing you here, that there are some ultrasound features which will tell you that this patient is likely having a malignancy. Ultrasound features are like, it's a multiloculated tumor. It has got solid areas and cystic areas, cystic solid areas together. That is what is known as a variegated mass. So solid areas and the tumors are bilateral along with ascites and metastasis. So this is the criteria, the ultrasound criteria, which suggests that this patient is probably having a malignancy. Then menopausal status. If this woman is menopausal, then she gets a higher score. If she is premenopausal, she gets a lesser score. And then the absolute levels of CA 125. So whatever is the level of CA 125, that is used, and all of these three are multiplied. So risk of malignancy index is A into B into C. So if it is more than 250, then we say it's a high risk that this woman is likely having a ovarian malignancy. So this is what we got to know from the question, and this is the additional information which we'll give you. All right. So these kind of questions are there in the QBank 6.0. Then another question. Now this is that simple one-liner question which you should immediately know the answer, right? Which quantification method is used for diagnosis of hirsutism in women? So when women are hirsute, how do we say, what are the places you look at in a woman's physique that it is suggesting that the woman has hirsutism? Number one, the criteria is known as the Ferriman-Galloway scoring. The Ferriman-Galloway scoring keeps getting modified in every edition of new books, but you should know it is the Ferriman-Galloway system. And when we know the Ferriman-Galloway system, please understand the side locks and the eyebrows, if they are thick, don't call a girl hirsute just because of them. All right, it is the areas like the upper lip, the chin, okay, the chest hair, the upper abdomen, lower abdomen hair, the thigh and the arm hair, and the upper back and the lower back hair. There are 9 places in the body which are assessed for the hirsutism. All right, so those 9 places I've shown you here: the upper lip, chin, chest, upper abdomen, lower abdomen, upper arm, inner thigh, and upper back and lower back. So these are the 9 areas which are assessed for saying a woman is hirsute or not. So how are we using them? If there is some hair growth on these areas, we give 1 mark. If there is excessive hair growth and thick hair in these areas, then we give 4 points. So the same areas are assessed in all these 9 areas. They are given marks, score from 1 to 4. So when it is extremely thick hair on the upper lip, we give 4 points for that. So if a score is less than 8, then she is not hirsute, and 8 and beyond, we say she is hirsute. So if the score is 8 to 16, we say she is mildly hirsute. If it is 17 to 25, we say moderate hirsutism, and more than 25 is severe hirsutism. All right. So let's see what you guys are conversing with me about. You're giving me the answers. All right. The question in the grand test of today. All right. So, okay, Shubham is asking me questions. Only rapid revision question bank के साथ NEET PG qualify. देखो यार, rapid revision Q bank will help you if you have already done your theory well. So if you've done the theory well from the app or any other method for that, I mean, I'm not going to say that the PrepLadder is the only source of information, but I'm sure that if you've done your reading already once, then go for rapid revision and the Q bank. Otherwise, you have to read once, my friend. You cannot just first read these things. Look, till your MBBS, all of you read well, but after MBBS, you have to give good 3 months to read the theory once again. Don't think that just reading MCQs and the rapid revision is going to take you through. you have to give, because this is the time when you understand all those subjects. There was a time when, all of us used to think that why there is a subject called PSM. At least we thought like that when we were we used to have finally a part 1. But when I became an intern, then I realized it's the most important subject, and I understood it so much better when I was an intern. Because when you become an intern, you've seen all the subjects, you worked as an intern, you burned the midnight oil, you've done all the hard job of reading the theory. Now you have worked in the wards, you worked the nights, you worked in the casualties, you worked in the labor rooms, and you worked in the emergencies, ICUs, and now whole medicine makes a complete picture in front of you. And then when you read PSM, it makes so much more sense. And then you think about, yeah, if I knew PSM so well in my final year part 1 exams, I would have done so much better in PSM. You realize that is such an important subject. So that's why I always say that during your internship, give 3 months to 4 months to read all the subjects once. So once you've done that, then QBank and the rapid revision is the best way to get into your PG entrance. All right. So right, let's move on and see some other questions. What are the other questions in the QBank? Okay, question ID 23947. What is the recommended treatment for masculinization associated with PCOS? Now, this is a very tricky question because here we've given you masculinization. Sometimes what happens in the exam, they say irregular cycles plus acne, or they'll say irregular cycles plus hirsutism plus hirsutes. So they can ask this question in many different ways, but all of you know there are common problems of a young girl with PCOS is what? One, she's having irregular cycles, and 2, she's having hirsutism. And of course, one of the manifestations of hyperandrogenism is the acne. So one of these things will be, one of these questions will be asked regarding this common problem of young girls, that she's got irregular cycles and hirsutism. So what are you going to do about it? Or masculinization also, like in this question, there's another variation, same problem. So young girls, they want regular cycles, and then they want to have relief from the acne or the hirsutism. So we combine drugs. We have to give estrogen, we have to give progesterone, and we have to give a anti-androgen. But now the progesterone action and the anti-androgen action is given by one drug, like cyproterone acetate or drospirenone. So that's why this in this we have the choice of estrogen plus cyproterone acetate. So ethinyl estradiol, this is going to cause the proliferation of the endometrium. Cyproterone is going to cause secretion of the endometrium, and it is also going to cause the anti-androgen action. So this is that wonderful combination where we are giving one drug for 2 actions. That is, ethinyl estradiol is given for the proliferation of the endometrium, and the cyproterone is given for the secretion as well as the anti-androgen action. So that's why this cyproterone, which is an inherent progesterone, will give the secretory action and the anti-androgen action. So that's why this is given to all the young girls who are having irregular cycles with PCOS and hirsutism. Another combination is ethinyl estradiol plus drospirenone. That's the other combination which is available in the market. Right. So that's about this. And you are giving me answers, or you asking me doubts? This question is also in the grand test of today. All right. Let's move on and see other things here. Okay, now that's a clinical question which you should know that you will get some questions like this also, good explanations, and you must correlate well. So 26-year-old patient has just delivered a newborn full-term baby girl in the labor and delivery suite. At 1 minute, the baby's APGAR score is 5. At 5 minutes, the score is improved to 7, but the baby looks lethargic. The baby's blood sugar is checked and it is 35 milligrams per deciliter. Yes, anything less than 70, we are worried. The doctor orders the nurse to infuse IV dextrose. On complete physical examination, the baby has fused labia majora. All right, please look at this one, fused labia majora, and other aspects of the examination are unremarkable. Which of the following is the most likely cause of the baby's condition? All right, take your time and give me an answer, because this is the one which came in your NEET exam a couple of years back. Yes, what are you guys answering? All right, most of you are getting the answer correct. It is congenital adrenal hyperplasia, correct. And when we say congenital adrenal hyperplasia, you know that the problem is mostly in the deficiency of 21 hydroxylase. And when 21 hydroxylase deficiency is there, there will be improper or reduced synthesis of the steroid formation. So if you look at this diagram, this you'll see the adrenal steroidogenesis here. So we know that the pregnenolone, which breaks down to progesterone, and the 17-hydroxypregnalone, which breaks down to 17-hydroxyprogesterone, this is going to give us cortisone, cortisol, and these are the adrenal steroids. These are the mineralocorticoids and these are the glucocorticoids. So when there is a 21 hydroxylase deficiency, steroids are not made, and when steroids are not made, then the patient can be having, you need steroids, and in a severe form of congenital adrenal hyperplasia, in addition to steroid deficiency, there will be also adrenaline deficiency. So when there is adrenaline and steroid deficiency, these are the counter regulatory hormones when there is stress, and they increase the body sugar. But if these are reduced, then there will be hypoglycemia also. In addition to this hypoglycemia, there will be also a problem of patient not making aldosterone. So there will be this sodium retention. This sodium retention is what is managed by the aldosterone. So if aldosterone is deficient, then there will be no sodium retention. In fact, there will be loss of sodium. So there will be hyponatremia, hyperkalemia to compensate for this loss of sodium, and there will be also dehydration. So this in the classical salt losing form. This in the classical salt losing variety can be even fatal for a newborn. All right. Now, in addition to this, we must understand if it's a girl child. If it's a girl child, boys are made because of androgens, girls are made because of absence of androgens in the intrauterine life. Now, what is happening when there is 21 hydroxylase deficiency? None of these are made. So the feedback of steroids to the brain is not there. So hypothalamus thinks there is no steroid. Hypothalamus stimulates the pituitary, and pituitary makes more and more ACTH, and that ACTH will stimulate the adrenal gland to break more and more cholesterol. So this cholesterol breakdown will increase, and this will increase pregnenolone, 17-hydroxypregnenolone, and these androgens. It will increase this progesterone, 17-hydroxyprogesterone, androstenedione, and the testosterone. Then all of this will go on increasing, and that's why this patient will have excessive androgens. And when there are intrauterine excessive androgens, the external swellings, I keep telling you, the external genitalia is because of the genital tubercle and the genital swellings. So when there is a genital tubercle and two genital swellings, and these, because of androgens, they will fuse, and this tubercle will increase to make a penis, and these two swellings will fuse to make a scrotum. And in a woman, they will not fuse, they will stay separated. So they will make a labia majora, and they will make a labia minora, and they will make a clitoris. Now what happens in a case of a woman having too much of intrauterine girl having too much of androgens? So when there is absence of androgens, a girl is made. When there are presence of androgens, a boy is made. But if a girl has androgens because of a congenital adrenal hyperplasia, a girl will fuse these swellings and make a scrotum. So what is actually fused labia? It is going to look like a scrotum, and the genital tubercle will increase a little to look like a small penis. So that's why the condition which I showed you here, this patient will be having this fused labia majora, and there might be a little bit of clitomegaly also. So yes, all of you got the question correct. I was trying to tell you, in the app we'll be giving you all the basics why this is happening even when you're doing the questions. All right, let's go and see another question. Question number 505719. Which of the following factors in a patient's history is irrelevant, all right, not important, to her predisposition to fibroids? Please take a look and tell me the answers. Which one of them is not important in the history of fibroids? All right, let's see what you guys are answering. Postmenopausal bleeding, people asking the question now. Okay, we'll get back to that since I already asked you a question. See this, we'll get back to your queries also. Okay, fine, all of you got this correct. Okay, this is a fairly simple question that, okay, it'll take you some time, but don't miss such questions, all right? Such answers which are a giveaway. If you've read fibroids, you should know this answer very well. A patient having fibroids will be because of obesity, family history of fibroids. If a woman has fibroids, her relatives or female relatives can have fibroids 2.5 times more likely. So there is a predisposition in women, and then also early age of menarche. That means early menarche, that means more exposure to estrogen. So all of these D, C and A, all of these are predisposing to a woman having fibroids, but having 3 children, this is protective, all right? A nulliparous woman will have more fibroids. So this woman has 3 children. She is actually protecting herself from having a fibroid. So yes, this was a fairly simple question, and I'm sure all of you got that correct. And you're asking me about what is the most common cause of postmenopausal bleeding? Look, postmenopausal bleeding, we are getting CA endometrium discussion somewhere here. Please say, remember very well, there is no doubt about having, I have done this exercise numerous number of times in my classes, and I'm doing it live again for you. All of you are interns who are writing PG entrance exam, and please tell me how many of you seen today. Raise your hands wherever you are. How many of you seen CS cervix? At least 70 to 80% of you seen CS cervix. How many of you seen C endometrium? Maybe, let's see how many people are there. 306 as of now. So all of you, how many of you seen CA endometrium? So when there is C endometrium, door please. So when you see C endometrium, remember CA endometrium is not more than a single case in a month in a practice, even in a maybe 2 cases or 3 cases, even in a a good hospital where there are well-to-do women coming, because C endometrium classically happens to diabetic, hypertensive, obese women. So even in a good private hospital where middle class and upper middle class women come, even there you will not see more than 1 or 2 cases of C endometrium in a month. But in a government hospital where the masses come, you will always see CS cervix coming. Every day you will see new cases, and you will see so many follow-ups, and CS cervix is rampant in our country. Okay, now CS cervix you've seen, C endometrium maybe a couple of you have seen. Now how many of you seen senile endometritis, which is the answer you people are going to discuss with me. That's some places the answer, in some books it is given as senile endometritis, somewhere in some places you must have discussed this also. How many of you seen? Come on, tell me, how many of you seen? Come, give me, come. How many of you seen senile endometritis? Okay, come. Okay, I'm waiting. Okay, my phone here in my hand. Tell me, how many of you seen senile endometritis? Come, show me. Show me, how many of you seen? Don't lie to me. Senile endometritis, come on, show of hands. And don't lie to me. So you only read it as a finding in your Novak's Gynaecology, Shaw's Gynaecology, because they're Western books. You've read senile endometritis there. Yes, it does happen. It happens in India also, guys. It's not that it doesn't happen in India, please. There are numerous women. Some of my relatives had senile endometritis, my senior relatives who I have taken care of. So please, senile endometritis can happen. But how many of you have seen? You don't even know where it is in the OPD. But you've seen CS cervix because it is rampant. So what is the most common cause of postmenopausal bleeding in our country? It is CS cervix. In the West, they say that yes, CS cervix is a lifestyle-based disease, and if you screen it, then you can reduce CS cervix. So yes, CS cervix is not so rampant in those countries. But yes, if the endometrium gets older, it is known as atrophic endometrium, and that atrophic endometrium has a tendency, it does not have estrogen because the woman is 55-60 years of age, and that endometrium cannot fight infections which could be ascending from a mild infection in the cervix or from the vagina. So that endometritis can happen to that atrophic endometrium, and that is senile endometritis. It bleeds. So it is a fairly common cause in the West because CS cervix is not there. So there it is, senile endometritis. In our country, we see so much of CS cervix that senile endometritis come way down as a cause of bleeding in the menopause. All right. So yes, even sometimes some exams in some universities, they've done these mistakes, because Novak clearly says endometrial atrophy causing senile endometritis. Even Shaw says that it is a common cause of postmenopausal bleeding. But yes, that's not in the Indian setup. Okay, so that is end of one discussion. Okay, so postmenopausal bleeding, what are the most? See, postmenopausal bleeding is not colposcopy. Postcoital bleeding, who is asking me this question? Dr. Saha, please, yes. So, Dr. Saha, please, postmenopausal bleeding, do not say that we will do colposcopy first. You will examine first, okay? Postcoital bleeding, also you will examine first, but in postcoital bleeding, you will say colposcopy first. Postmenopausal bleeding, you examine and you see, if you see a mass, you take a biopsy. If you don't see a mass, then you may think in terms of doing a Pipple endometrial biopsy in the UPD, all right? And TVS is a adjunctive, TVS is a good adjunctive investigation for you to work up a woman with postmenopausal bleeding. Not the first thing to do. First thing is to do, always examine. And if there is no local lesion on the cervix, then you're thinking of endometrial causes of postmenopausal bleeding. So you'll do a Pipple endometrial biopsy, or also called office endometrial biopsy. All right, guys, enough about that. Let's move on and see another question. So we've discussed a bit about this. Right, another clinical question. A 33-year-old male comes to the fertility clinic with his wife for preconception counseling because he was recently diagnosed with the Kartagener syndrome. His brother is also diagnosed with the same disease. It's an autosomal recessive disease, all right, and the brother also has infertility issues. The patient is concerned about the chance of infertility. The counseling doctor should explain that there is a chance of, why is there infertility in this patient? Now, this is that good clinical question, and like we always say, if there is a long clinical question, the answers are actually very simple. So, what is the answer to this question? So, yes, Kartagener syndrome, most of you would know that Kartagener syndrome is because there is a, primary ciliary dyskinesis. So, because of this ciliary dyskinesis, you may have a patient having not just the problem of sperm motility, you will also have problems of bronchiectasis, situs inversus, all right. So, all of these patients who are coming to us, recurrent sinusitis is also the clinical triad which you people keep reading. So, when this patient is present to us, we are thinking of infertility because of decreased sperm motility, all right. So, that's correct, and not sperm production, guys, it is because of the motility, asthenospermia, like somebody has correctly said, Dr. Purohit, right, that is correct. Right, let's move on and see. That was a long question with a fairly simple answer, right. So, okay, fine, I wrote that triad for you. Okay, let's move on and see. Now, this is that favorite MCQ which keeps coming in almost all your exams, whether you are a PG entrance student or you're a FMGE student here seeing this, questionnaire here with us. Please remember about trichomoniasis and bacterial vaginosis and candidiasis. Gynae point of view, please read about these vaginitis very well. So, 29-year-old female presents to the clinic with symptoms of vaginal discharge. The discharge is frothy, yellow-green in color. Okay, this itself will tell you something. Foul smelling, it may or may not be, but frothy yellowish green in color. The following organism was identified on physical examination of discharge under the microscope. Which of the following is the most likely causative organism? So, yes, you're seeing some flagella here in an organism which is motile. So, it's a flagellate protozoa which is Trichomonas vaginalis. So, yes, you must remember greenish yellow frothy discharge is trichomoniasis, curdy white discharge is candidiasis, and of course, the creamy discharge is the bacterial vaginosis. Now, most of the times they'll ask you such questions, but sometimes they might ask you, what do you see in bacterial vaginosis when you do a microscopy of the discharge? Will you see leukocytes or you will see clue cells? So, leukocytes are absent in bacterial vaginosis and you will see more clue cells. More than 60% of cells which you see in bacterial vaginosis are clue cells. So, what are clue cells? All right, vaginal epithelial cells embedded with bacteria. They may ask you not such simple questions sometimes, okay. They may ask you what are the features of complicated candidiasis, all right. So, please do take time, and of course, the answer to this question is Trichomonas vaginalis, definitely go and read this. Okay, I'll always show you this slide. Move away from the screen so that you can take a picture of this and don't miss out on this. All right, I've given all the details of candidiasis, bacterial vaginosis, trichomoniasis. I've discussed all of them individually in the app, but I've given all of these because most of the times you want to compare. So I've given you this slide always in almost all the presentations also which I do, so that you can compare. Okay, so remember, bacterial vaginosis has this Amsel's criteria, 3 out of 5 of these, creamy discharge, whiff test, then the fishy odor, clue cells, and alkaline pH. Okay, these 5, if they are present, then we say out of these 5, if any 3 are present, then we say the patient is having bacterial vaginosis. All right. Also, remember that bacterial vaginosis has no pruritus, whereas candidiasis and trichomoniasis, they will have pruritus. All right. So regarding this, are you asking me some questions? So let me see. All right, fairly simple one. Okay, let's move on. Okay, histopathology of staging laparotomy done for carcinoma endometrium reveals more than 50% myometrial invasion with vaginal involvement, parametrial involvement, but no pelvic and para-aortic lymph node involvement. What is the stage of C endometrium here? So now, nobody is going to ask you write the staging of C endometrium, but when you mug up C endometrium staging, you must remember that they will ask you a few stages more commonly than the other. One of them is inguinal lymph node involvement, second is bladder and bowel involvement, and the third is vaginal involvement. Any cancer, inguinal lymph node, any cancer in gynae I am talking, inguinal lymph node involvement, vaginal involvement, okay, and bowel and bladder involvement. So when we are talking about CA endometrium, vaginal involvement, which is asked in this question, with parametrial involvement, this is classically stage 3 and it is stage 3B. And I have always highlighted this in my classes that vaginal involvement in CA endometrium will come as a question. And now, vaginal involvement in CA cervix, upper vagina, lower 1/3 vagina. So 2A is CA cervix I am talking, 2A is upper vagina, lower 1/3 vagina is 3A. All right. So vaginal involvement in all the cancers, try and remember. In CA vulva also, lower vagina, upper vagina. So that is stage 2 and stage 3. Lower is stage 2 of CA vulva, and upper vagina is stage 3 of CA vulva. Mind you, CA vulva staging has changed. So those who are reading the app, please go and see the CA vulva updated staging has been given to you in the new app. All right. So please remember that all these areas, if you remember the staging well, well and good. If you don't remember the staging well, at least try to remember these specific areas which keep coming in your exams. All right. So what are you asking me about this here? Okay, the staging I'm giving you here. Why should I explain? I'll give you the complete staging in short. Whatever I do is in short. Yes, I always keep telling you everything in a way that it is easy for you to understand and recall in the exams. I would always try to tell you what I've seen with my clinical experience and give you in a way that it is much easier for you to grasp and recall in the exams. Giving you reams and reams of notes of CA endometrium is, I won't remember also myself so much. So yes, that is the staging in short of CA endometrium. Okay. So this is what we've discussed, that it is involving the vagina. So it is vagina and parametrial involvement is stage 3B, and pelvic and para-aortic lymph nodes were not involved. Now, what is the method of staging of CA endometrium? Might as well tell you that. So when we have a woman with post-menopause bleeding, like we discussed, stop looking here. Okay, stop reading that. Keep talking to me. So when we are talking about a woman who's having post-menopause bleeding, she's let's say 56 years of age, and when I examine her vulva, vagina, cervix, grossly everything looks fine. First thing to do in the OPD, examine it. If nothing is wrong, locally no lesions, then we do a pipil endometrial biopsy. I send the biopsy to the path lab, and the path lab comes out with a answer that the report saying that the patient is having CA endometrium. Now, if it is endometrium, I have to see the stage. It is involving the uterus. So far I know, when I did a biopsy, this endometrium, okay, this endometrium here, I've taken a biopsy. This is showing me a cancer. Now, I want to know whether it is spreading from the endometrium to the uterus or to the parametrium, going to the serosa, going to the vagina, all that I have to know. whether it is involving the para-aortic lymph nodes and the pelvic lymph nodes, this is also what I have to know. So what do I do in my management? The management is decided after knowing the staging. So how do I stage endometrium? I know it's a cancer. If a woman is 56 and she's having a cancer of the uterus, what are you going to do with that uterus? You're going to do a hysterectomy. So you open the abdomen, take the uterus to the path lab. Okay, do a hysterectomy, take the uterus. Now, along with the uterus, you want to know whether the other parts of the pelvis and the abdomen are involved grossly. I don't see any gross growth, but I will take some pelvic lymph node biopsy. I will take some para-aortic lymph node biopsy. So that is the step of staging of endometrium. All cancers in gynae are staged surgically except C cervix, which is staged clinically. So if it is a case of endometrium, I'm going to do a surgery, which is hysterectomy. So I do a hysterectomy plus pelvic and para-aortic lymph node sampling. So I take out this uterus, take a sample of this lymph node, take a sample of this lymph node. And when this uterus goes to the path lab, in the path lab, this uterus, just like my hand, I'm going to slice it and see whether it's going from the endometrium to the myometrium, less than half, more than half, or it is going till the serosa. Then I'm going to see if it is involving the cervix or not. So that is about the uterus and the cervix. Then I will see the lymph node which I sent, whether they are involved or not. So based on that, I will get the staging. So that's why you do the steps of staging, which will help you in the correct assessment of the stage of this patient. All right. So that's about the staging, and of course the treatment is not the purview of this small discussion which we are having right now. Anyway, if you're asking me something, let's see. No, Dr. Purohit Perak. Most common stage presentation 3B, that is for CS cervix, not for this. Okay, not for this. No. 3B is the most common stage presentation, CS cervix. Right. Let's move and see another question. A 30-year-old female gravid to para 1 live and presents to the gynecologist with complaints of passage of some products of conception following by heavy bleeding 2 hours ago. She is otherwise vitally stable and other general physical examination reveals no abnormalities. A diagnosis of incomplete abortion is made and the doctor performs an evacuation. He, however, doubts that it's a molar pregnancy and thus sends it for a histopathology. The point of distinction between a complete mole and a partial mole is, so basically we are saying that a woman was bleeding and something came out of the vagina and then the remaining was taken out by the doctor, and this product of conception from the uterus, pregnancy test was positive. This was sent to the path lab. What do you see in the path lab which tells you that it is a complete or a partial mole? What do you see in the path lab? All right, come tell me. It's a very important chapter, molar pregnancy. Please read it very well. And it comes, we see a lot of it in Asia, Southeast Asia more, and rice eating population more. That's why it's a common problem in our country. So please read about molar pregnancies and choriocarcinoma well. So yes, what is your answer? Come, this is an interesting one. What have you guys answered? 69XSY, that's a karyotype. Partial is triploid. D, a lot of people are saying D. Okay. Okay, most of you are saying D. So let's go one by one. So partial mole shows trophoblastic proliferation with absent villi. This is wrong. In a partial mole, you will definitely see villi. Okay, choriocarcinoma is where you don't see villi. So this is wrong. Typical of partial mole is diffuse cellular atypia. No, we see focal. We see focal cellular atypia, or we see focal destruction of the villi. All right. Partial mole is more prone to tumor malignancy. No, this is lesser prone. It is 2 to 4% versus a complete mole which is up to 20% chance of choriocarcinoma. And partial mole is triploid. So this is that. Those who saw D, maybe in the exam they're not going to give you such a easy choice here. Okay, so this was the easy choice. Partial mole is triploid. This is straight away your answer, because most common karyotype of partial mole is 69XXX. Okay. Now, what happens in a partial mole? There is maternal and paternal contribution to make this fetus. Of course, it's an abnormal fetus. 69XXX is not a proper karyotype. The baby is going to form, but the plasma is going to be partly degenerated, and the baby has a karyotype of 69XXX. It's going to spontaneously abort. But in a complete mole, as you know, complete mole has an empty oocyte with the sperm fertilizing it. So that is going to not give. In a case of complete mole, there is no maternal contribution. So in a complete mole, I am not going the total details. Complete mole, you have a karyotype of 46XX, but both the X chromosomes are paternal in origin. So that's the one fact which you should remember, that complete mole has both the X chromosomes as paternal, and partial mole has maternal and paternal contribution. So this question came in one of the NEET exams, that what is the final method of distinction between partial mole and complete mole. You know, all of this may give you an answer, but the final distinction is based on one fact, that yes, the P57 immunohistochemistry is present in a case of partial mole, but is not present in the case of a complete mole because it is of maternal contribution. All right. Okay. So this is present in a case of a partial mole and not present in a case of a complete mole. All right. Okay. So that's about this question. Let's move on and see another one. A 26-year-old woman who achieved pregnancy through in vitro fertilization undergoes a bedside transvaginal ultrasound at 7 weeks gestation. The ultrasound reveals the presence of twins at 7 weeks with 2 normal heartbeats. What is the most likely type of twin in this case of pregnancy? All right. So please tell me what type of twins you see in IVF. To me, it seems like a very straightforward question, and I'm sure it seems like a straightforward question to you also. Come, what type of twins you see in IVF? A. No, man, no conjoined twins. Why? You're trying to pull my leg, okay, Marut? Don't say conjoined twins. Why would you say conjoined twins, man? Conjoined twins is... Can you zoom the slide? Oh, it's too late for that. It's coming through my laptop and I am so sorry. Can you zoom in a little bit? Okay. Okay, let's see if it helps. Okay, my friend, my tech support is telling me that you can increase the brightness on your phone. Can you increase the brightness on your phone? That will help. All right, so a lot of you are saying D. Some of you are saying A and C also. So please remember, when we're doing IVF, remember, go back to the basics of IVF which I taught you. So I told that we are going to take out the eggs, we're going to take out the sperms and make embryos outside in the lab. And to increase the chance of pregnancy, I make more oocytes grow in this woman. So I, let's say, take out 10 oocytes from a woman and I get 10 embryos in the lab. I'm not going to put 10 back inside the woman because I want to get maybe 1 or 2 pregnancies. So I put 2 embryos or 3 embryos in the uterus. I transfer back embryos which grow in the lab. I transfer 2 or 3 embryos. So when I make the embryos, when I do the IVF, the embryos are of day 3, which is a 8-cell embryo, or a day 5, which is a blastocyst. All right. So when there's a day 3 embryo, it has grown 3 days in the lab, and I think it's a fairly good growth, that 3 days the embryo has survived outside the body of the parents and outside the body of the mother, and it's going to grow for 3 days well. It's a fairly good embryo. When it is a day 3, I transfer. How do I do the transfer? I do the transfer of 2 or 3 embryos back to the uterus, hoping that at least 1 will stick. Now, day 5, which is a blastocyst, it has grown 5 days in the lab. And when it grows 5 days in the lab, it gives us a guarantee that this is a much stronger embryo because it stayed in a foreign environment for 5 days without degenerating. So that is a much stronger embryo, much better quality embryo. And if it grows for 5 days, the chance of it implanting in the uterus is much higher than a day 3 embryo. So when I transfer a day 5 blastocyst, I transfer 1 or 2 embryos. Okay, so that is the basic which I keep telling you. Now you tell me, if I put 2 blastocysts, if I transfer, look, what's the meaning of what I'm saying? If I transfer with a cannula, here I transferred 2 embryos back into the uterus of day 5. These are day 5 and I transfer them back to the uterus. If I put 2 embryos back into the uterus and both implant, there are 2 different embryos which have gone inside. So it has to be dichorionic and diamniotic. All right. If I put 3 and out of which 2 implant, again dichorionic, diamniotic. Sometimes if I put 3 embryos, all 3 will implant. It has happened in our lives. I have had the experience of having 3 embryos implant when I have transferred 3, hoping that, I was hoping that at least 1 or 2 will implant. All 3 implanted. So that is what? Trichorionic, triamniotic. Trichorionic and triamniotic it will be. So don't get confused. Mostly this is what is going to happen. The number of embryos you put, they're going to implant. So dichorionic, diamniotic will be the most common type of twin. Okay. And yes, I've had a few triplets, maybe only a couple in my life. And what happens? One of them spontaneously mostly aborts. So yes, we've had triplets with other methods of assisted reproductive technology. We're not talking about all that right now. I'm just trying to tell you that mostly or 99% the twins which are made in IVF will be dichorionic, diamniotic. There can be a very rare chance, that I have put 2 blasts inside and the first one does not, this one does not implant, and the second one which implants, before implanting it splits into 2 halves. Can rarely happen that one embryo of day 3 when I transferred, that died, another embryo which I transferred, that split into 2 and made a monochorionic diamniotic or a monochorionic monoamniotic twin. That is extremely rare. I have seen only a few, very few cases like that. So please go ahead and mark what you said. D is the answer, dichorionic, diamniotic. Just remember this basic, you'll never have a doubt. Dichorionic, diamniotic is what mostly happens. Right, let's see another question. A 30-year-old primary graduate at 36 weeks of gestation presents to the emergency department with vaginal bleeding. 30-year-old, 36 weeks of gestation. Vaginal bleeding. Okay, the uterus is relaxed. On per vaginal speculum examination, blood is found in the vagina and the cervical canal is closed. Her vitals are 90/70. Blood pressure, pulse rate is mild tachycardia, 105. Respirate is 17 per minute. Her abdominal ultrasound shows a complete placenta previa, grade 4. Now this grade 4 won't be asked. Okay, so this mostly they will ask you totally covering or partly covering, or they may also say marginal. That's old classification again. So totally covering or partly covering. Old, what was earlier called grade 4, so we mentioned that for you to correlate. But that grade 1, grade 2, 2A, 2B, type 3, type 4, all of that is outdated. We are using only the totally covering and partly covering variety now. All of the following are appropriate next steps, except what are you going to do? Administer intramuscular terbutaline. Wait a minute. Terbutaline is a tocolytic. Arrange for units of packed blood cells. Okay, fine. Administer IV fluid, resuscitation. Monitor the urine output strictly from now on. Okay, fine. This is all to see how much of blood loss she's having, whether she's having adequate perfusion of the vitals. So if there is adequate perfusion of the kidney, there will be good output. Fine. So B, C, D is correct. Administer terbutaline. That's a tocolytic. If a woman is having bleeding, antepartum hemorrhage, abruptio placentae, placenta previa, vasa previa. If the patient is in the time before 37 weeks, that is known as preterm. But I'm not saying it is preterm labor. Try and understand this, okay? There can be a patient before 37 weeks. She's not at term. Let's say she's 36 weeks in this example and she's having bleeding because of, let's say, placenta previa, because of abruption, because of vasa previa. Where did I say she's having preterm labor? When did I say she's having preterm labor? So even if she's having preterm labor with this bleeding, don't give tocolysis. Anyway, I have not told you she's in preterm labor. So please do not say give tocolytic. First fact, okay, this is a tough question for you guys to understand. NEET PG students, please take very good look at this question. I'm saying the patient is having antepartum hemorrhage. She's a case of placenta previa. You will do resuscitation. What is the management of placenta previa when she's bleeding at term? Do a cesarean section after resuscitation. What is the management of placenta previa when she's bleeding at 36, 35? Already lung maturity is done. Again, do a cesarean section after resuscitation. Why do you want to give tocolysis? So she's 35, 36, she's preterm, right? Lung is already mature. Why do you want to give tocolysis? Anyway, you're not going to achieve anything. The lung is mature, take the baby out. Suppose she's having placenta previa bleeding. Suppose this was 32 weeks and it was placenta previa and it was bleeding. Again, I will not give tocolysis. Why will I give tocolysis? Tocolysis relaxes the uterus, and with the shearing action, there might be more bleeding in a case of placenta previa. All right. So please don't say you will give tocolysis in placenta previa. Okay. When she's bleeding, do not give tocolysis. Placenta previa, abruption, vasa previa, no tocolysis. I'm telling you repeatedly. You get confused because the timing given to you is before term. This is preterm. The time is before term. It is not preterm labor. Okay. So don't think of tocolysis. Now, NEET PG students, they asked you another question because of which this confusion is there. They asked you a question, a woman at 33 weeks, preterm labor, they've given you this information, 33 weeks, has come to you with preterm labor. On ultrasound, placenta is covering, PL, placenta is covering the os. Excuse me. Guys, this is a totally different question. It is preterm labor. 33 weeks, patient has preterm labor. Will you give tocolysis or not? Incidentally, the ultrasound shows there is a plaster covering the os. She's not bleeding. Where did I say she's bleeding? So it's a case of preterm labor. You give tocolysis, yes or no? Yes, you give tocolysis. Before 34 weeks, you must give tocolysis because you want to get some lung maturity. So yes, placenta previa, bleeding before 36, 34, 33, whatever, bleeding placenta previa, negative tocolysis. Now, this is a case of preterm labor. Give tocolysis. Incidentally, there is a placenta previa. Well, she's not bleeding. It is not of any botheration to us. Placenta previa happens to many patients. It's like asking, forget this one. Leave this. Preterm labor on ultrasound, the baby is in transfer line. Baby is in breech. Baby is oblique. How does it matter at 33 weeks? We are not trying to deliver, we are trying to stop the labor. So all of this information is given as a distraction for you guys. NEET PG guys, this question came to you. A patient is having preterm labor. Will you give tocolysis or not? Because the patient has a placenta previa. It is not bleeding. So go ahead and give tocolysis. So please, I've written both these situations. Take your time and understand what I told you just now, all right? It is there on YouTube forever now. So please read this and don't get confused, okay? Any questions you ask me about this? Okay, guys, drug of choice for tocolysis. Yes, go ahead and mark nifedipine as the best drug. Yes, one of the other good drugs is magnesium sulfate because that is the only neuroprotective agent. Okay. Clinical question again. A 26-year-old primary gravid presents to the antenatal clinic at 33 weeks of gestation for a routine checkup. Blood pressure is 170/100. Her lipid profile and cardiac evaluation are normal. She's got hypertension. She never had a raised blood pressure in the past and has no family history of hypertension. All right, this is a gestational hypertension. Her urinalysis shows WBC of 0 to 1 per high power field. That is all right. Albumin is 2+, which is significant proteinuria because 1+ is proteinuria. So 2+ is definitely no glucosuria and no pus cells. Which of the following is the expected renal change in this patient? So yes, they've given you hypertension in pregnancy and it is specific hypertension in pregnancy. She's not a chronic hypertensive. And when it is not a chronic hypertensive, what are the changes you are expecting on the kidney? Very specific question. NEET guys, this question came to you. Yes, what is that expected change? Come, what are you guys answering? Answering A, B, C, D. All right, what are you saying? Come on, I'm not seeing any answers here. Yes. All right, suddenly a deluge of B, 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 A, D. Okay, I think I got you with this one. So guys, please remember, this is that classical NEET question. Please go ahead and nothing less than Williams Obstetrics or PrepLadder, what I've taught you. You know, it is heavily inspired by Williams Obstetrics and what I've learned all my life from my college and what I've practiced. There's a lot of addition and lot of inspiration from Williams Obstetrics, because that's what has been asked in your exam. And go ahead and read the chapter from that book. Okay, now they've asked you this, and this is specific change is known as glomerular endotheliosis. Okay, so this is glomerular endotheliosis. This picture has been given in your app also. So normal endothelium, you'll see some fenestrations, all right, and the basement membrane. Now what happens in a case of preeclampsia? There's edema. So what happens? This endothelium is swollen, and because the swelling of the endothelium, these fenestrations, which is responsible for the perfusion of the kidney, these fenestrations will become occluded. So when they get occluded, perfusion to the kidney is less and there is renal damage, and damaged kidney will start showing proteinuria. So very important, this is the change known as glomerular capillary endotheliosis, which is seen in hypertensive disorders of pregnancy, especially the gestational hypertension. This is the change which you have to mention in the pathology. Right, guys. A primary rider presents at 36 weeks for a routine antenatal visit. Examination reveals a breech presentation. Okay, confirmed with an ultrasound. The mother wishes to know the chance of having a safe and normal vaginal delivery. Which of the following types of breech has the best chance of vaginal delivery? Now, first of all, this question should tell you that we do breech vaginal deliveries. All right. Don't say breech requires only cesarean section. I don't know why, you know, the whole of practice nowadays, anywhere in obstetrics, you think you see anywhere breech, go ahead and do a cesarean. Please, breech will deliver vaginally. You should be a good obstetrician who should sit with the patient and give her trial of labor. And if she's not delivering, go ahead and do a cesarean. That's why breech has to deliver in an institute, in a tertiary care setup where a senior obstetrician is always present, and it has to be under the supervision of a senior obstetrician. You cannot put a second year or third year PG to do this. A consultant should be there, not even a SR alone should do that, not a registrar. Okay, a consultant should be present to do a breech vaginal delivery. And yes, the residents, the senior resident and the junior resident should learn, and breech will deliver vaginally. First fact. Number two, breech are generally of the three types: the flexed breech, the extended breech, and the footling breech. Okay, so remember which of this, yes, can you tell me which is the most common breech and the best breech for vaginal delivery? Answer is the same, most common breech and the best for vaginal delivery. What's the answer you guys are giving me? C, complete breech. A lot of you are saying B. Oh yes, some of you did say A. Breech with the extended head. A lot of you saying D. No, man, this is something we will never give a normal vaginal delivery. Extended head, head is extended. So there is an extended difference. Okay, there's a difference, extended breech and extended head. So yes, quickly if I can make a diagram. Oh God, I'm bad at this. This is a flexed breech. Look, the legs are extended. This is the extended breech, and this is a footling breech. Okay, so this is a flexed, also known as complete. This is a extended breech, also known as frank breech, and this is a footling breech, also known as incomplete. So yes, the extended breech is the most common breech and the best for vaginal delivery. Extended breech. Okay, the legs are extended. So that's why we say, look at these, the legs are flexed, flexed breech or a complete breech. Extended legs, extended breech, all right. So this is both of these, this first one will deliver and the second one will deliver. Footling breech, do a cesarean section. So these two will deliver, and the best and the most common is the frank breech or the extended breech. That is the answer to your question. Now, there's another one where the head is extended, when the head is extended, whatever is happening below, we are not bothered. When the head is extended, suppose this is the nose and this is the eye here, extended breech, if the head is looking up, stargazing sign, extended breech is different from extended head. Extended breech is this, that is extended head. Extended head never give a normal delivery, because this head, when it is extended and you're pulling the baby out of the pelvis, the head will get stuck at the brim of the pelvis and you will definitely do a spinal cord injury for this baby, and these babies will definitely not deliver normally, and they'll have a injury at the level of the spine, and they could be a cervical fracture, a spinal cord injury, and you lose a baby. So if you do an ultrasound, see, confirm with an ultrasound that it's an extended breech. Lot of MCQs will come, it's an extended breech and the head is well flexed on the ultrasound. This is what will be written, and generally you miss out on that information. When the head is well flexed, in a case of breech, it's a good information. They may say the breech is extended but the head is also extended. Extended breech, good for vaginal delivery. Extended head, do a cesarean section. All right. I think some of you got this for the first time, but good. Footling has more chance of cord prolapse. Yes, that's why footling you'll do a cesarean section, already told. Okay guys, that's a good one. Let's move on and see. So, a 23-year-old female primary grada presents to a gynecological emergency room with a history of vaginal spotting and gradual onset dull right-sided flank pain associated with nausea and vomiting. The transvaginal scan shows no gestational sac in the uterine cavity. Spot serum beta HCG reveals the levels are 410 milli-international units, whereas the levels were 880 milli-international units 3 weeks ago. Laparoscopy reveals 125 milliliters of blood in the pelvis and a freely floating placental tissue in the peritoneal cavity. Come on, this is a giveaway. This is the easiest question with a very long description. Actually, very good, easy answer. So yes, the levels were 880 and the levels are reducing, and in the abdomen you will see free floating placental tissue. Uterus is empty. Obviously, this pregnancy is outside the uterus. So outside the uterus is an ectopic pregnancy, and mostly ectopic pregnancies are in the fallopian tube. All right. So this is a case of a ectopic pregnancy which has had a tubal abortion. All right. So this is a case of tubal abortion, and that is one of the termination events of an ectopic. Yes. You can have a vascular insufficiency, which is the most common termination event of an ectopic. You can have a tubal abortion, or you can have a rupture of a tube. But here the fetus came out of the fallopian tube, the values are reducing, patient is not very sick. She had around 125 ml of blood in the pelvis. So this happens many a times when we do an ultrasound. On the ultrasound we see there is some free fluid in the abdomen and there is no pregnancy in the uterus. So we think in terms of that there is a pregnancy test positive, and there is no pregnancy in the uterus, and there is free fluid in the abdomen. We think in terms of an ectopic. We go ahead and do a laparoscopy, and in the laparoscopy you will see blood around 200 ml, 300 ml blood also you will see. But a tubal abortion, you don't have to take out the tubes. The baby has already come out, you clean the abdomen and you see that the tubes are now nicely empty and there is no bleeding from the tube. You leave the tubes and come out. Of course, to make sure that there is nothing staying back in the tube and proliferating later, we give them some methotrexate, maybe a 1 dose methotrexate we give after this, so that if there is some part of some villi, coronary tissue, trophoblastic tissue staying in the tube and causing a persistence later, so that will also be totally taken care of by the methotrexate. So yes, that's the case of tubal abortion. Good. So most of you got that correct. So one more question. A group of researchers was conducting a study on vertical transmission. Which of the following infections has the highest risk of fetal infection in the first trimester? Very good question. Come. Highest incidence of mother to child transmission. That's a hint I'm giving you. Most likely transmission. UG करवा के भी देख सकते हैं ना? Ultrasound में I didn't understand. Ultrasound we did not see anything in the uterus, and in the small placental tissue which is very small floating in the abdomen, you will not see by an ultrasound. No, you will not be able to see. Answer is D. Okay, yes. Mother to child transmission in the first trimester is 90% in the first trimester. Syphilis is around 50%. Hepatitis A, very rarely mother to child transmission. Hepatitis B, no mother to child transmission. Guys, these are MCQs. Which of the following does not go during the pregnancy from the mother to the baby? All right, hepatitis A, hepatitis B does not transmit transplacentally. Yes, hepatitis B has a very high chance of transmission during labor. So we call it hepatitis B is a perinatal, okay? We call it a peripartum. During the time of perinatal or peripartum, transmission of hepatitis B is known to happen. Okay, toxoplasmosis in the first trimester is only 10% in the first trimester. It is 60% in the third trimester. All right, so rubella is 90% chance. It is known as the perfect teratogen, rubella. Okay, perfect teratogen, the kind of problems it causes. Okay, so a lot of you wrote C. No, C is wrong. D is the correct answer. Most of you got that correct. All right. Okay, triad of congenital cataract and deafness, and okay, fine. That you know well. Very good. Right. A 32-year-old primary gravid prince due to excessive postpartum bleeding after a vaginal delivery. A prolonged second stage of labor complicated this delivery. A perineal tear is found on examination as shown in the figure below. So in this perineal tear, you are showing there is an anal sphincter which is torn. This is the anal sphincter here, and rectum is also torn. Okay, so anal sphincter is torn and the rectum is. Oh, you're not able to see the choices. Let me see if I can help you. Let me see, reduce the size a little bit for you guys and pick it up. All right, guys, now I think you can see it better. Okay. Come. What are the choices here and what are you guys answering? See, ruptured ectopic won't be educational ideas, will not be such a stable patient, and you know, you'll not have the chance of doing all this serial HCG measurements. When there's a ruptured ectopic, it's a much catastrophic kind of a presentation mostly. So the patient, you'll not be able to do HCG which was 880 and after a few days it was 410. That kind of thing is done for chronic ectopic or these tubal abortions. That kind of follow-up. Ruptured ectopic will be a drastic, catastrophic presentation. So classically for PG entrance, we'll ask you straightforward questions. We'll not give you this. We get all kind of combinations. Ruptured ectopic, and you know, it becomes a chronic hematocele in the pelvis, and it goes on reducing the HCG very slowly even after rupture sometimes. Can happen, but we are not talking all of that with you. Okay, we are giving you straightforward pakka situations in life. So that was a straightforward tubal abortion case. Okay, so all of you got this correct. All right, when there's a rectal tear, then we call it a 4-degree perineal tear. Okay, so most of you got that correct, 4-degree tear. So first degree is only the vagina, and second degree is plus the muscle, that is vagina plus muscle, and third is vagina plus muscle plus anus, and 4 degrees all of these three plus the rectum. And remember, the 3rd degree tear and the 4th degree tear together is known as the complete perineal tear. I'm not saying that they both have to be present, please. If it is 3rd degree tear or a 4th degree tear, that is, both are known as complete perineal tears. All right. So complete perineal tear, when will you repair? Come, you've just done a delivery. 2 questions I'm going to ask you. Okay, when a woman had a complete perineal tear, you've done a forceps delivery, you take out the baby and the perineum is torn and it is communicating with the anus. When do you repair it? Repair it immediately, obviously. You've just not done a forceps, you see a tear, you repair it immediately, take her to the OT, give her anesthesia and suture the anus in layers, and then you suture the muscle and you suture the vagina and then the skin. Patient has delivered in a village. She comes to you after 7 days saying, sir, I had delivered in the village and after delivery, my baby is fine, but I'm not able to control my stools. My stools are coming out without any control and I keep soiling my garments and I'm having this big problem. So I examine her and I see that she's got a complete perineal tear. She had delivered in a village. Baby was around 3.7, 3.8, slightly big baby, and she has torn her anus and she's having incontinence of stools. When I'm going to repair this woman? That's the question. Come, I want the answer. A complete perineal tear which has come after 24 hours. When do you repair it? All right, all right. Okay. Oh God. Oh, and this is so interesting. Everybody saying 3 months. Perfect answer, guys. So happy that you said that. Please don't say 1.5 months or 6 weeks or 20 days. Please, you want this area to heal. Suppose this patient comes to me after 7-8 days. So after 24 hours, these curtains have all got embedded with bacteria. It is colonized with bacteria. So when it is embedded with bacteria, you cannot suture it with a on an infected curtains. You cannot put a suture. Okay, so you have to wait for these ends to heal with secondary intention. Yes, you want these areas to get nicely scarred, and when they are scarred in 3 months with a good healing, the curtains are healed. I'm not saying they will close. The curtains are healed, then your repair will hold. So that's why 3 months. Okay, so two places: a vesicovaginal fistula, 3 months; a case of complete penile tear which is neglected beyond 24 weeks, again 3 months. Okay, both these places the answer is 3 months. Right, guys. A 35-year-old woman presents with complaints of amenorrhea for the past 1 year. She is mother of 2 children. Her second pregnancy was complicated by severe postpartum hemorrhage. She also stated that she could not lactate after the second delivery. All right. But after that, she remained asymptomatic. Skull radiography shows empty sella. What is the most likely diagnosis? Yes, this probably, my good friend Dr. Marwa should be taking care. But yes, it keeps coming to us also in the exams. Yes, keep coming to us as cases when we were obstetricians trying to pass an MD exam. Yes, this was one of the cases which came in my DNB exam. Yes, in my MD exam, of course, we got something straightforward. This was my long case in my DNB exam. Yes, guys, of course, you guys know the answer, obviously. Yes, most of you are answering C. That is a Sheehan syndrome, postpartum pituitary necrosis. Yes, you know that very well. Postpartum pituitary necrosis is something where, woman has PPH and that temporary, loss of blood pressure and loss of blood. You will give blood, you will give IV fluids, you will resuscitate, you will give drugs which will cause the uterus to contract, you will save the patient. But the temporary hypoxia, pituitary is extremely sensitive to that. And that pituitary apoplexy, like they say, it is what is going to cause the necrosis of the pituitary and an empty sella. All right, and this patient is going to have syndrome not just of lactation failure, then all the pituitary functions will be lost. So that's why it becomes a classical endocrine case, in addition to us having a problem, obstetrician having a problem of lactation failure in their patients. Right, guys, so those are the questions, those are the type of questions. A lot of one liners, but plenty of good long questions with clinical situations which come in our regular life as obstetricians, the regular life of obstetricians and gynecologists, not the rare questions. We are not going to ask you rare syndromes which present to us. Okay, the recurrent molar pregnancy syndromes, we are not going to ask you those in the exams. We are going to ask you molar pregnancy and the chance of becoming choriocarcinoma and the treatment of choriocarcinoma. We may ask you what is the problem in a choriocarcinoma if there is metastasis on more than 8 sites, or if there is a woman who's got this type of blood group. We may ask you such questions because you should know the WHO prognostic scoring system. You should know all the 9 features at least. I'm not going to ask you the details of the scoring, but I'm going to ask you what are the parameters of the scoring. And then I may ask you what is the chemotherapy given, at least the drugs which are given, if not the doses of those drugs. Doses have not yet come, fortunately, for any chemotherapy. Most of the subjects I can take, responsibility of saying that, but it can come. So that's why you must read the questions which are, the clinical situations which are regularly coming in your life. So that's why I say internship is that wonderful time of your life where you see questions coming from what you see in your day-to-day life as interns. So for that, you must be going to the wards regularly, right? And spending more time in the clinics than, trying to bunk and prepare for the exams. So I always say those who work very hard in the internship have always got the postgraduate in the first attempt. Never mind, those who are writing for the second time, they're going to do even better. Okay, so don't get angry with me on that. So what are you guys saying? All right, belated happy birthday. Okay, thank you so much. Those who remember, yes. Oh, I totally forgot about that. Thank you so much, guys. This Platin Love from Hyderabad. Dr. Lulu, thank you so much, as always. Confusion regarding critical value of HCG. There's no confusion, okay? 1500 and 6500. Use those values. Some books do say 2000. So more than, if you want to tell me, more than 1500 milli-international units, you'll see SAC on TVS. No confusion. And more than 6500 milli-international units, you'll see SAC on TAS. That's all. Bas. Don't get into confusion after this. Right, guys. So I hope all of you will utilize the question bank 6.0 for your benefit and do more and more revisions with us. And we are not just giving you answers, we're giving you the whole, explanation of why this choice is the best answer, why the other choice is not the best answers for this, and why this is almost the answer but not the right answer for this question. So we are trying to create those situations for you. Of course, they are one-liners also, they are recall based also, but you know that these kind of questions are becoming a rarity. We give you out of 300 questions in exams, you get around 100 odd questions which are the easy ones and the one-liners ones, but the other 150 odd to maybe 200 questions are the ones which are clinical situations, and those are not very difficult. Those are clinical situations which you see in your day-to-day life, not the rare questions. All right, so please don't see rare syndromes and go for the exam. Read what you see in your clinics repeatedly. I'm saying in your final year MBBS and in your internship. All right, guys, so it was wonderful having taken this quick session. We'll be meeting for the LRR for the INI-CET again very soon. So until then, it's good luck to you guys who are preparing for the exams. Thank you so much for staying so long with me.